two more here. One, under the definitions of a practitioner or a bona fide practitioner-patient relationship, the sub-item 1, a practitioner and patient have a treatment or consulting relationship during which the practitioner has completed an assessment of the patient's medical history and current medical condition, including an appropriate in-person physical examination. My concern is our healthcare systems just sold their e-visit platform and we're promoting, especially in the days of COVID, online visits with your physician. And so to require an in-person visit is kind of going backwards from what, again, I know the intent, but it's taking us backwards from really something that our community should be very proud of, that we've pioneered e-visits and e-physician visits. And so it concerns me that we're requiring an in-person visit.
Yeah, a couple thoughts on that. One is I understand from a technological point of view what you're referencing, and I know you understand the intent, which is to make sure it's a bona fide relationship. I think from an industry point of view, the concern would be kind of like was alluded to earlier in the meeting about a doctor on the phone, an out-of-state type $50 consultation, and here's your, here's your card. Go forth and conquer. The other piece I would mention in the definition section is this is, again, restates state law. And so even if this were stricken from the proposed body of ordinances, it's still going to be the law in South Dakota.
But is this state law or is this proposed rule that isn't finalized yet?
It's state law.
It's state law.
In, yeah, 34-20G.
Okay. I guess, again, my concern is that we're, as a governing body, telling a physician how to treat and how to act with their patients. Again, it's an overregulation thing where, again, in Section 3, it talks about the practitioner is available to offer to provide follow-up care and treatment to the patient, including patient exams. I think, even Dr. Aker sees patients in the emergency room where he wouldn't be able to do follow-up care. He would send you to your internal medicine provider, or he would send you to another provider. And so it takes his ability, if he chose, whether he used cannabis the way it's licensed to be prescribed, or uses it in an off-label process, which I think is also part of this overall process. So again, we're trying to, as a local governing body, get into the place of regulating healthcare providers. So that takes me to the next question.
If I may, Counsel, on that,
yeah,
good point. One of the things that I would point out is that from a state law point of view, the consultation piece, and again, you understand the intent with the sensitivity of the substance itself, but it does allow for just that consulting relationship during which the due diligence would be a review of their medical history and that sort of thing. The other thing I would mention is the state law definitions upon which we're relying were drafted by a proponent of this, and so it really isn't the legislature or anyone else who drafted that up. It's one that really the state is relying on the definition as proposed.
Okay, so this takes it as under definitions. We're talking about practitioners, and it defines a practitioner as a physician. And I know in South Dakota that mid-level providers, nurse practitioners, and physician's assistants do write prescribed drugs or scheduled drugs. Is it the intent of this ordinance to take them out of the prescribing ability?
Well, yes, again, dealing with a sensitive controlled substance, I'm sure the intent, although I can't speak to the drafter's intent. We don't have legislative intent here. We have drafter's intent. But what I presume is that it's to elevate the prescribing source or authority to an actual medical doctor, as opposed to someone who it may be a little more concerning if somebody without that level of credential would prescribe it.
Okay. One more, and